This is electrocardiogram we will discuss about today. Dr. Kyo, what do you think about this ECG?
Dr. Phil, will you please speak louder?
This shows an average flow back then in US value between 3 is LBBV pattern.
Dr. Sokchol, what do you think? This ECG, you.
This line was there was all formula to the QA.
Let's do it in it.
There was regular with the same output files. So one definitely the white forest. Factors is narrow. This is inferior and right side, so inferior to the right. Or this way. Ventricular origin flores with a functional root flores. So ventricular rhythm and functional rhythm.
What is the atrium doing? Do you see any atrial activity there? Okay, that means what? What possible explanation for that? You have to tell us what's the happening atrium, as we discussed, and then you're going to go down to whether the atrium has any relationship to QRS. So there's any PR interval, anything. So you don't see any of those, right? So clearly, maybe atrium is going on one way, ventricle going the other way. But there's a narrow complex rhythms that there is an atrial activity correlating with the QRS complex. Okay. So then, if you in that sense take a look at try to look at that way again. For example, look at the V1. What is that baseline doing? What do you think? What looks like that baseline? No, not QRS complex. Baseline between the QRS complex. What do you see? V1. It's kind of a noisy a little bit, wavy, right? What kind of heart rhythm can do that in atrium? If you have a very coarse atrial fibrillation, can do that, right? So therefore, your differential diagnosis is going to be atrium could be standstill or dissociated, but we cannot see because of maybe falling into the QRS complex. So is it a manifested surface ECG? Third would be atrial activity is so chaotic, like Dr. Park explained chaotic about wave dynamics of atrial fibrillation, then your wave pattern going to be changing constantly, but it looks noisy, okay? Especially somebody has been taking anti-arrhythmic drug. I want you to look at the AVR, very first complex, the PR, yeah, just before that, little to the left, little to the left.
Left. Yes.
Right here. What do you see?
And also rhythm straight,
Okay,
that too.
what do you see? So kind of a too bumpy kind of a guy kind of shows up there. Also, you can see an AVL as well. Extrapolate a little bit there, right? So that suggests you what? Very low amplitude atrial activity, somewhat, maybe regular, may not be, but they may be more consistent with maybe flutter, fib, things like that, right? So that proves that the atrium is not a standstill. There's atrial activity going on. Okay. Now you read the QRS complex as a lap bundle, right? This is typical lap bundle? This kind of notching? Do you see that in the inferior lead? You don't see that typically in lap bundles, inferior lead, right? But also you look at carefully in the lead 3, there's some sharp spike in before this every QRS complex. What that is? Pacing marker. Okay, so pacemaker. Now, sometime when you look at this carefully, this signal is predominantly sharp but more negative. Is that a little bit? This guy's a positive. Is that pacemaker tell you something about that? In other words, your pacing spike is a positive in AVL. That means is coming opposite direction of that. Where that be? So I don't know if people look at this carefully or not, but a 12-lead ECG pacing spike can tell you whether your pacemaker lead is actually. We don't look at that carefully, because the modern pacemakers, bipolar lead is very small, so they are seldom see. However, if you increase the output, you can see higher spike. So you're coming from somewhere inferior to the leftward this way. So gotta be right ventricle, right? Can be left ventricle. If a left ventricle, that would be isoelectrical negative. So when you interpret the pacemaker, things like that, you gotta look at everything. Now, what happening here? You said you described it very well. Narrow complex mixed with the going on here. So this pacemaker rate is regular or irregular? First of all, what do you think? Somebody need a caliber here to measure this thing. So if you measure RR interval, they are fixed to stable, then this is a fixed rate of pacemaker perhaps at the baseline. But if RR interval shortening gradually, this is a rate responsive pacemaker. So I'm telling you all about this potential explanation here. In my eye, it looks like a rate vary a little bit. So I would do favor for rate response so far single chamber pacemaker. Okay, what I see, I don't know, it could be dual chamber, but an EKG manifests in a single chamber. Then what happened here? This guy here. This might be patient's native complex, right?
Yes.
Next one, what?
Native again.
Native again, you think? Why is it a little different?
Same.
Because this is a rate variation of the atrial fibrillation. You can see slight change in QRS amplitude duration time to time. This one, what do you think?
That is different curve.
Yeah, different QRS complex. But then you don't see any pacing spike before this guy. Where might be?
Oh, there is before.
Right. So almost, yes. So basically, this is fusion between these two, and this what we call fusion complex, because we have an atrial fibrillation capture the venous went down, same time pacemaker fire. So then you can already tell based on this what is the minimum rate that this pacemaker programmed. Okay. So then subsequent takeover, same QRS complex, the pacemaker took over. So what you can conclude, this is a single chamber pacemaker, positive rate responsive, and then sensing is proper. If this is a program rate of the pacemaker, you can confirm that by interrogating your pacemaker, cross-match with this, make sure that your pacemaker function is normal. So if you see a patient with a pacemaker clinic, you program the pacemaker, you got to have a 12-lead EKG documented, because the pacemaker program alone will not tell you all this information. Sometimes you believe that the pacemaker interrogation say that 100% pacing. In reality, pacemaker don't see ECG, only see its own marker. That means may not be capturing at all the reality. Okay, or pacemaker fail to sense, things like that. So during the training for fellows, they forget to often get a 12-lead ECG in clinic. It is important unless you're monitoring real-time ECG telemetry all the time while you're doing this. So you have two options. One is display 12-lead ECG, maybe 3 leads or so, or after programming, get 12-lead EKG, confirm that what you done. It's very much essential. Now, anything else happening here? It is pacemaker complex, QRS. You see gigantic something in back here. What is this? What do you call? What do you guys usually call? This is not a T wave, right? This is U wave, right? Now, if this U wave is appropriate, next question you have to ask yourself, is it normal? Because also you can see in native complex. And QT is long, okay? So try to get all the information as much as you can in the 12 ECG and put you on the list and then start making sense out of it. So since the QT is long, patient may be in antiarrhythmic drug or some sort of a treatment for atrial fibrillation. You can imagine that in your clinical history. Or patient has an electrical imbalance, can be responsible for the U wave, again U wave, and so on. Okay. So this is basically single chamber pacemaker, possible rate response, appears to be properly sensing in patient who has atrial fibrillation with a possibly intermittent, whatever, slow bradycardia because the pacemaker driving most of the time. So patient most likely has 600 symptoms, they even know the conduction disease. Maybe that's why they got the pacemaker. Now, if this was a septal pacing, okay, CSP, these are very popular. This is a good placement? Next question I'm going to ask you. Because a single chamber pacemaker could be CSP, could be just regular pacemaker, right? What do you think about this ECG of a CSP? Is it good? We're going to have to ask a more senior guy now. What is this EKG? B1. Look at the B1. Is it acceptable? I don't know if it's a CSP, but if this was a CSP, since this is a teaching for fellows, B1, you should see what? And you see that? No, it's isoelectric. Right. So, yeah, right. So if this was a CSP, then you need to divide the lead. Not good. They have to reposition the lead to get the proper pacing. But this single chamber, then you will be satisfied with the capital threshold, sensing, and then you're done. Okay? Anything else? Because the time is a little short today, so we're going to move ahead. Next, let's show the next trace. Okay?
Telemetry, we just only have a V1 and V5.
Okay. Any difference? Pretty much the same, right? But you notice that the telemetry, you don't see pacing spike. You see that? The reason that is that the telemetry has used a different frequency filtering setting. Okay? So don't believe just looking at the telemetry and then you try to make a diagnosis of a pacemaker axis and so forth. You cannot see it. But what is this guy here? This one, and also this one. So this, very pretty regular, looks like 1, 2, 3, 4, 5. What do you make out of that? And then pacemaker rate is, it looks like a more regular now. So maybe you can argue what? Retrograde P wave or independent pacemaker atrial activity? Because it looks like that whatever the activity here is positive, lead 3, we can see. So it cannot be coming below, maybe above. If that's the case, if you imagine here some sort of regular rhythm here, almost, maybe this is a flutter, sensitive with the regular QRS complexes. Then maybe this is virtual pacemaker sensing only the pacemaker flutter every third or fourth beat or something like that. So that's another difference of diagnosis we have to put it on. So it is possibly could be virtual pacemaker, but not 100% sure. Okay, because we do not be sensing this wave here in pacemaker because you got refractory period and you got pacing post-pacing refractory period to fall into it. But there's something else here. So okay, what else? Anything else we want to add it here? Comment, please. Okay, move on.
This patient is 73 years old, male. She came with severe shortness of breathing, classified as class 4.
Okay.
And when she arrives at the ER, her initial saturation was 61%.
Okay.
And the symptoms started about 7 days ago. And also she discharged from hospital 2 weeks ago. And regarding her past medical history, she has a history of decompensating heart failure. The trigger is still unknown. Also, she has a good kidney injury, CKD. It's mostly related to cardiac syndrome. And she has a ischemic cardiomyopathy with the reduced ejection fraction. And in 2020, she had ICD implantation or secondary prevention after experiencing triple tachycardia. And in 2012, she underwent the repair of liver mitral valve, but unfortunately, this progressed to severe MR. And she also has atrial fibrillation and cavity surgery in 2020. And also, she had all stroke, disease, diabetes, and hypertension treating with tablets.
Sick patient. Got every disease in the earth. So what's the plan now? We got CVMR, all this going on. This obviously she had already previous surgery. So this is not a very good candidate for the redo operation on this patient. I don't know the surgeons willing to tackle that, but I don't think it is. Age of 70 plus all the multi-organ failure, renal disease. No, I think she will go to the acute renal failure post-operatively. This is not a very good candidate, unfortunate. So, what the ICD interrogation showed. Then maybe you can do something for her.
In May 25, she had ventricular tachycardia.
Mm-hmm.
Ventricular high rate episode detected by ICD, and heart rate was 200, older than 200, and lasting for 23 seconds. During this episode, once delivered 6 ATP and 2 shocks, and
Okay.
the episode was diagnosed at cycle length was 300 milliseconds, and was be determinated after shocking.
Okay, so she has a severe severe mitral valve regurgitation now. Okay. And the echocardiogram, she has a single chamber ICD here, looks like a BVI right there, 70, right? So then you have a 60 backup rate, and then you got the impedance is a 70, and then there's no rate response here. I can tell. Let's see. Well, this interrogation is a little bit unusual. And so she doesn't have atrial lead, it looks like. Is that correct? Or Tanda, one made another, but it looks like it did not interrogate. And then her basically doesn't say much about the capture threshold, anything like that. This right where the capture threshold, the 1 millisecond. Wow. And then the pacing setting is at 2.5. Okay, pulse width is okay, so impedance at 340. So debate would be if you make her basically, since she's mostly driving by ventricular single chamber pacemaker or defibrillator pacing, would be a candidate for the IV upgrade at this point. What is the advantage of IV upgrade in CVMI patient? Is there any role for that? You know, some patients who had surgery and then who already have bundle conduction system disease, they can develop progressive MR after the open heart surgery, especially when you pace patient from the right ventricle. Sometime putting out ventricle LV pacing lead in the other side, the proper place, you can improve mitral valve regurgitation by preventing desynchrony. Okay, so this is maybe only thing you may possibly consider doing for this patient because she's so sick and not candidate for the operation. And so, and then I think it may be something that you want to entertain possibility whether she has enough renal function to do that. That might be something you can do. So improve the QRS complex and narrowish, and maybe hope to improve ejection fraction and improve some degree of mitral valve regurgitation. Okay. And I think that's no guarantee, but that's the only thing you can, I think you can try here, EP standpoint of view. But she's not having any ICD shocks or frequent shock, anything like that. So then I don't think don't want to do pretty much anything. That's anything else we recommended for this patient at this point.
First, he came to the hospital.
There's a pulmonary edema, yes. You got bilateral pleural effusion, yes. Okay. Much better, but it still got an effusion bilaterally, not resolved. And then you still got a chest atelectasis lung here. So you got to do some more breathing exercise for this woman. She expanded that lung a little bit. And I don't know, I cannot see this post-cardiomegaly. There's probably also atelectasis there and also here. So you need to have a more aggressive respiratory therapy and physical therapy this patient if she can, and then seriously consider for maybe, you know, LV lead because her IV lead looks like a pretty decent position anterior subtalar area. So if you could have put on other side, maybe you can improve this a little bit. Okay. If she had the ICD lead over down here, that would be worse scenario. But it looks like she got subtal lead here, some degree. Because I would definitely consider doing that. Anybody have any other suggestion? Okay, this is AFib. So when she's not pacing much, so now is much better. But still, yeah, very much less. Yes, then you don't need probably IV ICD.
We can consider the IV upgrade, but
Not at this point.
it is not
No.
Reimbursed.
No, plus risk
And
too high.
also, there's no clear evidence.
Right. Because she has a
It works for the patient.
she got an intermittent fusion here. This one, some degree, different degree of fusion going on. This one compared to this, so very minimum fusion. QRS is still narrow, so then you won't have probably much choice.
So we discussed with the heart failure physicians,
Uh-huh.
they are, because surgeons are
Right.
not willing to do
Absolutely.
redo surgery,
Yeah.
so they're planning to clear the mitral cleave, but they're probably the ejection fraction is overestimated because of the CBMR.
I see.
So after tear, if the ejection fraction reduced, then we can upgrade the CRTD.
Okay, but I don't know whether you needed to because she's not pacing much. Then
But
I'm not
actually,
sure.
I'm concerning he got the appropriate ICD therapy more than 8 times this. Here, probably the worsening of heart failure contribute to
Right.
ICD therapy.
One thing we want to know whether what is going to happen with when you're tapering your dobutamine all the way down, maybe heart rate drops as well. That's something that balance between two. Okay, so we need to
The
think about
reason
that.
why I asked is Georgia presented this case is that I monitor the telemetry and it looks can you see the telemetry again? It's typical wide QRS complex tachycardia fusion bit and
Right.
capture bit.
Yeah.
First one capture bit,
Mhm.
and the other one fusion bit.
Mhm.
So at the time, I cannot differentiate it from the pacing rhythm versus slow BT.
Yeah.
But the 12-day
AIVR.
stage during
Yeah,
pacing
This is
is
AIVR.
exactly same
Yeah.
axis. So
Yeah.
it is-
This is a pacemaker rhythm that we saw. This is AIVR, and it's not a BT. So there's no really indication to ablate or anything crazy like that. This is idiopathic axial ventricular rhythm. They usually happen some other external factors that like perfusions, improve or other drugs, things like that. So you want to find the answer. But certainly at that small notching that we see, also we see in the pre here as well. Okay.
So the conclusion is don't touch this patient. Dr. Kim, now clear? Okay.
Don't touch no, you can touch, but you cannot do procedures. And you need to touch a patient, okay? But I want you guys to touch the patient, see the patient, examine the patient. I know some people these days, some juniors don't even carry stethoscope, don't take even history. They already collect the data from the previous medical history, things like that. Those not acceptable practice, especially when you're in training. So I trust me, closer you get to the patient, better off you are, always. Your patient knows that. If you care about the patient, you will not be too much trouble touching patient, talking to them, get to know them better. And I always tell you, patients are the best teacher of your life. Trust me. Okay. Also can be worst enemy of yours. Okay. So there's a two-faced of a knife. Try to use it wisely. Very important.
Hey, thank you.
Very good.
So 9 o'clock we have to, 2 minutes. We have 2 minutes.
Who's the presenting case now? Oh,
Sorry.
so keep going, keep going.